a native of Bhimavaram, so it's always great pleasure visiting Vijayawada. I thank Dr. Ramesh Babu, Karthik and their team for inviting us for this interesting seminar. Actually, it is Heart in the OR, because usually in all the conferences 1 or 2 lectures are conducted and the whole day has been dedicated to this, which is a very important topic in our practice. We always see a lot of cardiac patients coming for non-cardiac surgery. It's a big segment now in the practice, and it's a great pleasure and privilege to have my esteemed colleagues and friends, Dr. Bhimeshwar, Dr. Mahesh on the podium, and Dr. Suresh and Nima here, and with our Guru, Dr. Tagore there. It's a great pleasure, sir, to be here. And let me go to the topic. And my two previous speakers have made my life much easier, especially Dr. Gopal, by covering about the pre-op assessment and risk stratification, which is the most important part of this management of these high-risk patients. So I'll be dealing with the introduction and with general principles of anesthesia management, because I'm not going to go into the details because this is a mixed crowd of physicians, cardiologists, surgeons and anesthesiologists. So I'm not going to go into the deeper parts of the anesthesia, just the general principles, and if the time permits, couple of cases discussion. As already mentioned, there is a number of major surgeries performed worldwide are going up continuously, and the 30-day mortality associated with moderate to high risk patients is more than 2 to 5%, and cardiac complications are the most common cause of morbidity and mortality in the surgical patients in the perioperative period. This also increases the length of stay in the hospital and also the cost to the patient. Coming to the pathophysiology, why these patients demand a specialized anesthesia planning or peri-op planning? Because if a patient is having a coronary artery disease, there will be a supply and demand mismatch issues in the perioperative period, which can lead to a major cardiac events. Same way, if we are taking up a heart failure patient for a non-cardiac surgery, we have to manage the preload and afterload because they are sensitive to those, and also we should not be giving anesthetics which reduce the contractility. By doing so, we will be worsening the heart failure. So same way in the valvular lesions, we have to look at whether the patient is having a stenotic lesion or a regurgitant lesion. Based on that, we have to plan our anesthesia and fluid management. Same way, all these patients coming for non-cardiac surgeries, they are prone to arrhythmias. We may get a fresh onset atrial fibrillation or ventricular tachycardia, so we have to prevent, and if they occur, we have to manage. So this is about the gross principles. So this has already been mentioned, because why we are worried about taking a patient for especially a coronary patients for a non-cardiac surgery, because we are worried that MI can occur in the perioperative period. More than the instance on the table, it is for the first 48 to 72 hours, these patients are more prone for developing a major cardiac complication like having a MI. There are a lot of factors in the perioperative period which can precipitate this, especially the inflammatory response, which can lead to hypercoagulable state or plaque rupture. Same way, the neuroendocrine stress response also can increase the heart rate and blood pressure, and then that can increase the oxygen demand, leading to a perioperative myocardial injury. The inflammatory response can lead to hypercoagulable state, thrombosis, and then can lead to decreased oxygen delivery, precipitating a perioperative myocardial infarction. So our perioperative management, especially the coronary patients coming for non-cardiac surgery, has to do to prevent this or reduce the inflammatory response and the neuroendocrine stress response. So perioperative evaluation has been well covered by Dr. Gopal. We have to take a detailed history, and we have to estimate the functional capacity. We have to do the detailed physical examination, and appropriate investigations like echo, ECG, and the biomarkers have to be done, and if needed, a stress testing has to be done. If the patient is on having a device like a pacemaker or ASCT, then we have to interrogate the device and then do the appropriate management of that device. Coming to the risk stratification, various indices are there, and most common and popular indices index what we use commonly is the RCRA, which may not be the best, but I think currently available. It is one of the simpler ways of estimating the risk stratification. So in our center we tend to use the RCRA commonly, and we all know that the high risk cases are, not all cardiac cases are high risk cases. So the cases with a recent MI, unstable angina, decompensated heart failure, or a patient with a severe AS, or a patient with lower ejection fraction, these are the cases which are high risk conditions. And surgically also we have to divide the surgeries into low risk, intermediate, and high risk surgeries. This is about the RCRA index. If it is more than 3 risk factors are there, the risk of MACE, that is major adverse cardiac events instance, is more than 5%. So these are the category of classification into low, intermediate, and high risk surgical risks. So the investigations, the management, everything should be based on the patient condition, that is whether patient is a high risk patient or a lower risk. The surgery is a high risk surgery or a lower risk surgery or intermediate risk surgery. You can't be doing all the investigations for a cataract surgery even if he is a high risk patient, because the chances of any adverse events are less in low risk surgery. So this is where we have to use our knowledge and the clinical experience to do what type of investigations, and we have to plan our perioperative planning based on the risk of the patient and the type of surgery. So we have to optimize those patients. If we have time, or many of the patients are elective patients, when they come for elective surgeries, we should optimize their conditions so that we can avoid the complications in the perioperative period. Especially many of these patients, they are hypertensive patients, they may have arrhythmias, and electrolyte imbalances are quite common. So we need to control the hypertension, we need to correct the anemia if it is there, and if the patient is having a heart failure, then we have to optimize the condition by using diuretics. If the patients are on beta blockers, we should continue the beta blockers in the perioperative period. If they are on ARBs or AC inhibitors, then we should withhold morning dose, that's about 1 dose. If we withhold, the chance of hypotension is less. Same way, if the patient is already on anticoagulation secondary to atrial fibrillation or secondary to valve replacement, previous placement, or if they are already post PCI, we should manage the anticoagulation part as per the guidelines. So coming to the choice of anesthetic, this is what is the major discussion actually. So none of the major RCTs, any of them have proved whether the GA or the regional anesthesia, there is no difference in the outcomes. So it is sometimes, people have a thinking, and many of the times we also get like when we send for a physician opinion, some of the physicians tend to write patient is fit for spinal anesthesia or fit for regional anesthesia. There is nothing like that, because none of the RCTs have shown any difference in the outcomes between a general anesthesia and a regional anesthesia. So the choice of anesthesia should be with the anesthetist to decide depending on the patient's condition and the capability of the unit, and based on the guidelines. If the patient is on anticoagulants, you have no choice, you have to give GA. So based on, even on the surgical duration, we have to plan this. So both regional and general anesthesia, both of them have their own problems, have their own positive things. Suppose, for example, general anesthesia, it is very safe. If the patient is unstable, actually you have control on the respiratory system. If you intubate and ventilate under general anesthesia, you can reduce the respiratory workload. So it is safer in unstable cardiac physiology patients, but there is a chance of tachycardia and hypotension during administration of the anesthesia, in general anesthesia. Same way, when you come to regional anesthesia, the best benefit is the stress response blunting is better with regional anesthesia, whereas the risk is with the sympathetic blockade, that is with a spinal anesthesia especially, there can be a hypotension. For example, aortic stenosis coming for a inguinal hernia, you give a spinal anesthesia, more chance that the patient can develop hypotension and can have a problem, rather than giving general anesthesia to a particular patient. So our anesthesia management perioperative planning should be based on these factors. Same way, combined techniques. Sometimes we have to use combined technique. We use epidural with general anesthesia, especially if there is upper abdominal surgery like a hepatectomy or a Whipple's procedure in a cardiac patient. We give epidural, and also we give general anesthesia. So we give combined with adequate and appropriate monitoring. Same way, like Dr. Gopal has mentioned, these peripheral nerve blocks, especially the ultrasound guided blocks, have become safer and safer, and the expertise is increasing for the anesthesiologist. So we are able to give in very difficult cases where GA may pose additional cardiac risk to the patient. We do tend to give the regional blocks, ultrasound guided blocks. So they are good for not only intraoperative, most of the time for the post-op pain management, these ultrasound guided blocks are very, very good. So as I mentioned already, choice of anesthetic technique and agent. The guideline says in patients undergoing non-cardiac surgery, use of either volatile based anesthetic agent or a TIVA is reasonable for general anesthesia with no apparent difference in the associate MACE. In patients undergoing non-cardiac surgery, neuraxial is feasible. Either neuraxial or general is reasonable with no apparent differences in the outcomes. So there is no difference between regional anesthesia and GA. In GA also there is no difference in outcomes whether you use a TIVA or a volatile anesthesia. For patients who undergo major abdominal surgery, use of epidural analgesia for postoperative pain relief, it decreases the incidence of perioperative cardiac events. For patients with hip fracture waiting for surgical repair, nowadays we give block on arrival. If the patient is in pain, they give in the emergency itself the block to prevent the pain, which can precipitate a cardiac event in a already known cardiac patient. So most important thing is the monitoring. What makes difference is the monitoring. When the technique is not making much difference, what makes a difference is the monitoring. If you monitor the patient appropriately in a better way, you can prevent the events. For example, when compared to a NIBP, if you insert a arterial line, invasive arterial line, then you can get beat to beat blood pressure and you can detect the hypotension much earlier than in case of a NIBP. Same way, if you have a central venous catheter, you can administer the vasopressors and then you can prevent the hypotension and low cardiac output. So the cardiac output monitors are now available in all the tertiary care centers, like the flow track monitor, the PICO monitors, and also the non-invasive cardiac output monitors are also available. If you institute a appropriate monitoring, then you can prevent the events. Same way, TEE, all of us cardiac anesthetists, we use TEE. In case of even non-cardiac surgeries, if they are with a very high risk and a major procedure, or if intraoperatively if there is any event or a major thing, you insert a TEE and then you see if there is any fresh regional wall motion abnormality or a fresh MR developing, you can see. This is especially useful in major cases, like even in liver transplants, they tend to use the TEE more often. Same way, in all these cases, what is important is ST segment monitoring is very, very important. We should put 5 leads instead of 3 leads for these patients and display 3 leads on the monitor, one covering the anterior wall, one covering the inferior wall, one covering the lateral wall, so that any change during the procedure we can make out, because ECG is quite sensitive. You do get a ECG change in the monitor. Of course, I am not telling about the routine monitors like pulse oximetry, TCO2, every case we use. That's a basic monitoring now. Only about the advanced monitoring, as and when appropriate, we should use. See, this is one of the advanced monitors. We tend to use it quite often now in all major cases like onco surgeries and all surgeries. We have this advanced cardiac output monitor with the dynamic indices. We can use same way. TE is available nowadays, and expertise is also available. We can use. I'm not advocating using it in every case, but in an appropriate case, in an appropriate clinical setting, I think we should not hesitate to use a high-end monitoring. So now coming to the hemodynamic goals. Once you establish the monitoring, so each case, depending on what pathology they have, you have to have a hemodynamic goal. For example, if it is a coronary artery disease patient, we should avoid tachycardia and hypotension, and we should have a mean arterial pressure goal within 20% of the baseline. So we should also see that we don't increase the heart rate, because increase in heart rate is the worst thing you can do to a cardiac patient, especially coronary patient. That is what precipitates the perioperative MI. And as far as possible, we should preserve the sinus rhythm. Because the atrial kick is so important that every patient, we should try to maintain them in the sinus rhythm. Or if they lose the sinus rhythm or immediately they get into atrial fibrillation or something, we should make all efforts either by using appropriate medication like amiodarone or even cardioversion. We should convert as early as possible to the normal sinus rhythm. Same way, use of vasopressors with minimal heart rate impact, because when you need, if there is a hypotension, you start dopamine, then what happens is the heart rate increases. That can be jeopardizing the myocardial oxygen demand supply mismatch. So it is better to use agent like phenylephrine as a bolus, or an noradrenaline, or even vasopressin, which will not increase the heart rate. Same way, titration of the inotropes is also important. So coming to the induction strategies, goal is always to maintain adequate coronary perfusion, avoid tachycardia. So we tend to use in known cardiac patients etomidate, which gives a more stable hemodynamics compared to propofol, and mostly our anesthesia will be balanced anesthesia, but based on the opioids like fentanyl, and now currently remifentanil is also available. We don't use high doses of propofol, especially in severe LV dysfunction, because they can develop hypotension, and we use lignocaine to blunt the laryngoscopy response. And pre-oxygenation is very, very important if they have a limited cardiopulmonary reserve. Coming to maintenance, we mostly use balanced anesthesia techniques using volatile agents and also opioids. We avoid agents causing tachycardia, especially ketamine. And volatile agents are safe, but we avoid deep anesthesia in patients with poor ejection fraction. Same way, TIVA, that is total intravenous anesthesia, is useful for a tight hemodynamic control. Opioids are very much useful for blunting the surgical response. And neuromuscular blockade, we tend to avoid the histamine releasing drugs like atracurium, which can precipitate a hypotension in case there is a histamine release. Now coming to airway and ventilatory management, we should try to avoid sympathetic surges during laryngoscopy. If it is a difficult intubation, we should use video laryngoscopy, and then we should ventilate with lower tidal volumes, maintaining pneumocapnia, and avoid the high PEEP in case of RV dysfunction. Coming to vasoactive strategies, based on the need, we should use vasopressors like norepinephrine. And if patients with low EF are coming for major surgeries, based on the cardiac output, we should either start them on dobutamine or milrinone. And we should avoid ephedrine because it tends to increase the heart rate. Coming to fluid management, cardiac patients, they don't tolerate either hypovolemia or even overload. So goal-based therapy should be used using dynamic indices like SVV, the stroke volume variation, and pulse pressure variation. Crystalloids are preferred, and we should try to avoid excess of saline. It is better to use vasopressors early rather than rushing fluid in cases of cardiac patients, especially with lower ejection fractions. Arrhythmias, as I mentioned earlier, we should, as much as possible, try to prevent them or correct them immediately, or do the rate control using beta blockers and amiodarone. Special situations, in case severe aortic stenosis, we should maintain adequate preload and increase the afterload. In case of severe MR, we should avoid bradycardia. This is one condition. We prefer to have a tachycardia and maintain a forward flow. Coming to postoperative care, it is better to keep them in ICU for in case if there is a major surgery done in a patient with a known cardiac disease. In our unit, we tend to keep them for about 24 to 48 hours in the intensive care unit for better monitoring and early intervention. What happens is if they are in the ward, we tend to miss out on this one. So, and multimodal analgesia is administered, and we plan to do early mobilization and oxygen therapy. So, I will just go through a couple of cases because Karthik has asked me to put at least a couple of cases. I was discussing with my colleagues. I said I have to prepare some case scenarios. One of them suggested, why don't we discuss the cases we have done in the last couple of months. This is a case of acute coronary syndrome with a fracture of femur. On 18th November, this patient got admitted in a nursing home with a fractured femur, posted for PFN next day. But next day morning before the surgery, early morning, she developed left-sided chest pain and shifted to our hospital, and her ECG showed significant changes. And immediately she was administered loading dose of antiplatelets, shifted to cath lab, and coronary angiogram was done. Coronary angiogram showed severe left main with DVD. Echo showed severe LV dysfunction. IABP was inserted, and PCI was done immediately in the cath lab with two stents. One is LMC to LAD and to the circumflex. And but unfortunately, next day the patient developed limb ischemia, and IABP was removed. This is the ECG. You can see the acute changes have settled after the PCI. So he shifted to ward after 3 days from the ICU, but put on loading doses were given of both agents, then put on aspirin 150 milligrams because the patient's relatives were pestering us to do this surgery, and Clexane was started. After the multidisciplinary team meeting and high risk informed consent were posted for PFN, and facial ATA block was put in. Advanced hemodynamic monitoring we have put with BIS monitoring. We have planned for GA because the patient is on the anticoagulants, antiplatelet agents. GA was administered with fentanyl, etomidate, rocuronium, and propofol. Infusion was given and reversed with sugammadex. Extubated and shifted to patient in to ICU in stable condition. But later, after a few hours, she developed hypertension, and they have to start noradrenaline in the postoperative period. So these are the guidelines. We are not supposed to do, but because it's an emergency, even the patient is on antiplatelets, we are taken up. We don't have any choice, and we did it under GA with adequate advanced monitoring. These are the guidelines about the I'll stop with this last case. This is a post DVR, like our chairperson was asking. A double valve replacement was done, and the patient came for a emergency decompression craniotomy. Our unit is both neuro and cardiac active unit, so we tend to get this quite often actually. See, anticoagulants are double-edged weapons. We sometimes get with thrombosis, stuck valve, or other way also. This is a 58-year-old male patient, underwent CABG with DVR in 2023. 2 years back on a citrone 3 milligrams, acosprin, clopilate. presented with acute CVA with cerebellar infarct in the ICU. We did an echo which showed a thrombus bar vegetation on the mitral valve, whereas aortic valve process is probably he has embolized from that thrombus. He was put on anti-edema measures. Initial this one was to manage conservatively because the patient is on antiplatelets and anticoagulants, and put on anti-edema measures. INR was 2.5. Acetylene was stopped. Clopidogrel aspirin also were stopped and started on Clexane. But there was sudden drop in GCS after 2 days after the admission and was intubated immediately, and FFP was administered to control the INR, was taken up for emergency decompression craniotomy. We took a high risk consent. We made the blood products available, both the platelets and the FFP. Monitoring, we have put a arterial line CVP and advanced hemodynamic monitoring. Anesthesia was administered with fentanyl, midazolam, propofol infusion, and of course etomidate for induction, rocuronium, and we gave mannitol. We have administered PRBCs, FFP, and platelets were given. Postoperatively, the patient was ventilated. He needed noradrenaline. Tracheostomy was done. Probably the best thing would have been we should have done a TEG, that is thromboelastography, to see the coagulation parameters, but we don't have TEG at our unit. Nowadays, the recommendation by the societies is to give the 4-factor prothrombin complex. The octaplex is available. If we administer that, we can bring down the INR very fast. We need not wait, whereas vitamin K will take longer time. FFP also will take. Sometimes the patient may not tolerate the FFP, giving so much of FFP, 6 units, 8 units of FFP. But that is where the role of this 4-factor prothrombin complex, this one is there. That is available commercially as octaplex. But the cost is about, it works almost in the dosage for 2.5 INR we calculated is working about ₹1,00,000. The patient said they can't afford, so we couldn't give. Probably in this case, TEG and 4-factor PCC would have been a useful addition. Later tracheostomy was done and he was on the ventilator. So I'll stop here. Thank you, and sorry I have exceeded the time. Thank you for your attention.
Session is open for discussion.
I'm a general surgeon. I'm Dr. Ravi Babu. I'm having a question for you.
Yes.
There is one particular patient who is having what is that chronic liver disease, end-stage disease, who needed cardiac liver transplantation. But on evaluation, it was found that on angiogram, it was found that he is having a double vessel disease. Left anterior descending and then circumflex, and also in RCA there is a lesion, but functional